If you guys have any questions after each presentation, please write them in the chat on the side. And we're going to answer all questions at the end of the presentation. And I would like to also Mending Kids, what we do, we provide free surgeries to children worldwide. And we provide in this symposium sponsored by Edward Life Science. And I would like to welcome Dr. Berman. He's going to be our monitor, and he's going to be introducing the presentation for all our panelists. Thank you, Dr. Berman, for joining us this morning.
Thank you very much, Christina. First of all, I'd like to welcome all of you, those of you from Dar es Salaam that are joining, and from those of you from elsewhere from around the world. Thank you for taking the time and energy for joining us today. I'd like to thank both Christina as well as Isabel from Mending Kids for their time and energy and dedication to this. This is our third symposium that we've been putting on virtually, and we hope that this one is as engaging and interactive as the last two have been. Thank you to all the speakers for taking the time and energy out of their busy schedules for joining us today as well. I hope that this is enjoyable for all of you. I think we've gotten a good group together to give different perspectives on the different talks that we put here. And then lastly, just want to say that I hope that everyone is staying healthy and staying well with their loved ones, with everything that's going on around the world today. So I hope that everyone is safe and well. And without further ado, I say we just jump in and get started. So we're going to start off here with the first talk from Ruchira Garg, who has spoken before in one of the previous symposiums. She is a pediatric cardiologist and advanced imager from Cedars, Sinai, and she's going to talk on some of the common causes of congestive heart failure associated with congenital heart disease. So Ruchi, if you want to share your screen and take it from there.
Great. You know, Darren, I think I am not able to share it at this moment. Perhaps it's host disabled.
I'm hoping our IT help.
Now I think we're good now. Fantastic. Okay, can you see my slides?
Yes.
Yes.
Fantastic.
See them nicely.
Okay, wonderful. Well, thank you so much for inviting me again. This is really an honor to be able to share a little bit of knowledge with such a wonderful organization and practitioners across the world. I think this collective sharing and Zoom-based learning is just bringing a wealth of information to all of us. And I have the honor of starting the talks today with discussion of common causes of congestive heart failure in congenital heart disease. We'll talk a little bit about anatomy, pathophysiology that results in the symptomatology and the clinical presentation. My disclosures here, none of which are relevant to today's talk. So unlike some of the rest of the symposium, we're going to be talking about a different type of congestive heart failure, which is essentially defined as when the heart does not pump as well as it should be. And I prefer that general definition for the context of congenital heart disease, because when we think of congestive heart failure, and certainly when our parents think of congestive heart failure, there's the concern about pump failure and left ventricular dysfunction, because that is the overwhelming majority of patients in adulthood whose left hearts fail for various reasons, and then they have significant congestive heart failure symptoms, which we'll talk about. But in contrast, in the context of congenital heart disease, many of our patients exhibit symptomatology that's quite comparable, but have preserved, if not supernormal, pump function. It's just that the expectations that are placed upon their hearts are just overwhelming, and so they manifest the same symptoms of heart failure without that actual pump dysfunction. The most common etiology for congenital heart disease related heart failure is pulmonary overcirculation, and then pulmonary venous congestion a little less commonly due to obstruction of the left heart can also cause congestive heart failure symptoms, and rarely, even more rarely still, a combination of both. So we'll go over a little bit about that. When we think of overcirculation lesions, we're really talking about cardiac and extracardiac shunts. And I like to think of these in two separate buckets: the pre-tricuspid valve shunts on the left side and the post-tricuspid valve shunts. And you can see the pre-tricuspid shunts essentially are atrial septal defects, anomalies of the pulmonary veins, and in rare occasion, an important coronary fistula that may be draining into the atria. And these, I make the distinction because they are rarely as symptomatic, rarely cause as much long-term effect as the post-tricuspid shunts, which are listed to the right. But before we go into the specific lesions, to really understand the physiology of congenital heart disease in babies and children, it warrants a brief discussion of the postnatal transition physiology from fetal life to newborn life. So for a brief review and maybe an introduction for some of you, prenatally, the lungs are really not doing any work in that fluid-filled placenta, fluid-filled sac. So the placenta is delivering oxygen-rich blood to the right side of the heart, and it joins the blue deoxygenated blood from the body. And then there are two bypasses of the lungs. One is the patent foramen ovale, and the other is the patent ductus arteriosus, with the goal of getting all this mixed oxygenated from the placenta, deoxygenated from the body blood, essentially to the body. So at birth, the pulmonary artery pressures are very elevated because they are essentially systemic the entire prenatal life. And there is a transition where the pulmonary artery pressures fall. Persistent fetal circulation, as depicted in this diagram, shows the spillage of deoxygenated blood still from right to left into the aorta, and from the right heart to the left heart, resulting in some cyanosis. And that's when there's delay of that transition. But what normally should happen is that the pulmonary artery pressures fall to somewhere around a quarter systemic, 25% of the pressure in the aorta. And that happens in a period of days to weeks. Now, the PFO and the PDA typically close, and if there are no shunts, then you have a QP-QS ratio, pulmonary blood flow to systemic blood flow ratio of 1, as shown here. Blue blood confined to the right side and red blood confined to the left side. But when you have a left to right shunt, like a VSD, like a patent ductus arteriosus, you have left to right shunting, so systemic oxygenated blood back to the lungs a second time, and that's too much pulmonary blood flow with a QP-QS ratio greater than 1. And that is, of course, because those pulmonary artery pressures fell. Right to left shunts are defined as usually too little pulmonary blood flow, with blue blood going from right to left. So another way to look at this a little bit visually is the clinical impact of the shunts are a function of the pressure and flow. So the lung pressures, systemic pressures are essentially equalized at birth. And then as the pulmonary artery pressures drop, there is increasing left to right shunting from the systemic circulation to the lung circulation. And this causes symptoms. So the pre-tricuspid shunts, I have a few shown here: atrial septal defects anywhere within the septum, total or partial anomalous veins. This may be familiar to those of you who signed on for our last symposium. And these patients rarely exhibit symptoms of congestive heart failure if they don't have other things like obstructive lesions. And there's rarely a late onset of pulmonary hypertension or Eisenmenger syndrome. Post-tricuspid shunts, in contrast, they manifest hemodynamic significance sometimes within days to weeks after birth, as that lung pressure is trying to drop. So those PA pressures started as systemic, and then they should be down to the lowest point at 6 weeks. And the bigger, the more distal the shunts, the earlier and the greater the symptoms. So I mentioned Eisenmenger syndrome in this one slide, I wanted to point this out, that the progression is starting with a left to right shunt in early infancy, which increases that pulmonary blood flow. But at a certain point, that the pulmonary architecture needs to remodel because of the overwhelming amount of blood flow and pressure and volume stress. So there's smooth cell proliferation, there's abnormal remodeling, vascular remodeling to deal with that high pressure and volume. And then that's when you start to again increase the pulmonary vascular resistance and pressures, and then end up with an inverted shunt with irreversible right to left shunting, or the cyanosis and Eisenmenger syndrome, essentially coming almost full circle from fetal transition. So what does that look like with a VSD? We can start with a left to right shunt 3-to-1 or even greater in early childhood, and these babies are very symptomatic. Then with that remodeling, that shunt decreases because the pulmonary vasculature accepts less of the pulmonary blood flow, until eventually you have that reversal of shunting with a QP/QS ratio less than 1. So we certainly want to avoid at all costs this point, but generally patients are quite symptomatic when they're in the early stages to alert you to the fact that they're having congestive heart failure. So let's look at a diagrammatic representation of truncus arteriosus. These are babies that often will present with some degree of cyanosis because they have this complete mixing, blue blood mixing with the pulmonary venous return, resulting in relatively well-balanced saturations. But they can't control the amount of pulmonary blood flow that's going to their lungs. And so the pulmonary pressures start to drop, which further increases pulmonary blood flow. And within a week, most babies with truncus arteriosus have so much pulmonary blood flow, pulmonary venous return, their oxygen levels actually may increase, so they're not cyanotic, but they're having significant symptoms of congestive heart failure. So as much as they can be managed medically, we try to do that, but typically surgery is done before they go home because of the excessive amounts of pulmonary blood flow. Single ventricle anatomy is another typical lesion that can result in congestive heart failure due to overcirculation. And these two can have cyanosis from mixing, like you can see here, pulmonary blood flow coming in, systemic blood flow coming in, mixing. But if there is no restriction, no limitation of blood flow to the lung artery, the blood is always going to choose to disproportionately go to the lungs rather than the aorta, as the pulmonary pressures and pulmonary vascular resistance decrease. So what do we do in these scenarios? Because we have such an imbalance of pulmonary blood flow, we try to restrict the amount of pulmonary blood flow. One way is with a pulmonary artery band to, again, favor more systemic flow at the cost of a little bit of cyanosis, or put in a systemic to pulmonary artery shunt to, again, give a regulated amount of pulmonary blood flow and not this unrestricted forward or antegrade flow through the pulmonary artery. In contrast, tetralogy of flow does not typically cause patients to manifest congestive heart failure, because one of the cardinal signs of tetralogy of flow is pulmonary stenosis. You see the tight narrowing and the restriction of blood flow to the lungs. So while these patients are cyanotic, they typically do not have congestive heart failure unless they have the lesser common variant of pink tetralogy, where they don't have much pulmonary stenosis at all. So this is the same list I showed earlier, the lesions that are at risk for congestive heart failure. They're all mostly post-tricuspid ventricular septal defects, complete canals, single ventricle physiologies we discussed, truncus arteriosus, and then when you have double outlet right ventricle with unprotected pulmonary blood flow. And the goal is to medically manage these patients as well as possible, either until a defect like VSD or PDA gets smaller and may ultimately resolve spontaneously. The patient gets a little bit bigger for a more successful lower risk surgery. And then sometimes until symptoms just push one to have to go forward with surgery. And the goal is really to avoid this irreversible pulmonary hypertension or Eisenmenger syndrome. So what does the clinical presentation look like? Murmur is often present with these lesions, either due to increased flow through the pulmonary artery, increased flow across the diastolic flow across the atrioventricular valves, but you may have an absent murmur early on when there's not a lot of pulmonary blood flow. Cyanosis, as we discussed, may be present, especially if you have mixing lesions, but also cyanosis can occur when you have so much overcirculation that you get pulmonary edema and poor gas exchange at the alveolar level. And then the cardinal congestive heart failure symptoms are symptoms of tachypnea, diaphoresis or excessive sweating, tachycardia, and failure to thrive due to inadequate feeding. What I tell my patients and families to give them some sense of expectation of what their babies are going to look like is I ask them to think about how they look, how they feel when they do intense aerobic exercise, when they're running, when they're pushing themselves. They are sweaty, they're having a hard time keeping up with their breathing rate, drinking water without choking. And when you think of elite marathoners and people who exercise all the time, the number of calories that they have to take in can be double or even triple that of those with more sedentary activity. So that's what congestive heart failure symptoms really are manifesting, is an inability to keep up with the demands that are required for that lesion. And then by echo, we see left heart dilation in these patients when the QPQS ratio is greater than 1.5. I should, sorry for the typo there. So I want to do a quick clinical presentation. This is a triplet that was born at 30 weeks of age, and a murmur was not heard until 10 days of age. And premature infants can have some delay in the drop in their pulmonary artery pressures just by nature of the immaturity of their pulmonary bed. The echo demonstrated a large membranous ventricular septal defect and quite a large PDA. The diagram here shows this very large PDA. The descending aorta is right here. You see this large PDA. Red flow is showing the flow into the pulmonary arteries. And there's a very low pressure. By echo, we can measure the pressure differential between the aorta and the pulmonary artery through this. And so there's a little bit of a pressure difference, so not too much symptomatology, but over time there is drop in PA pressures. This is the VSD here going into the right ventricle and then out to the pulmonary artery, and there's very high velocity flow. This is the large VSD, same size as the aortic valve. By this point, the PDA had closed with medical management, but at 2 months of age, this baby has torrential pulmonary blood flow, was receiving 150 kilocalories per kilogram per day, with the typical amount being about 100 for this age of a baby, needed both nasogastric and oral feeds, triple diuretics, electrolytes to correct the diuretic dyscrasias, and then beta blockers, which have shown some benefit in overcirculation congestive heart failure. There's still cardiomegaly, pulmonary edema due to the overcirculation, and significant left heart dilation, more than was seen in the original echoes. So to finish off, just 1 or 2 slides on obstructive lesions. This is a whole additional talk, but when you have left heart obstructive lesions, these babies also will manifest very similar congestive heart failure symptoms to an adult who is having pump failure. But they may often be more severe. Medical management is often minimally effective in these babies, still diuretics and the conventional management may work for a time, but ultimately surgical correction is required of that obstructive lesion. So in summary, on this whirlwind tour, congestive heart failure can be to a myriad of congenital heart lesions that cause left to right shunts and left heart obstruction. Medical management has a very important role, but may not be adequate and require intervention if we can't get adequate growth or expect reduction in size of that shunt. And then surgical repair or palliation is required to protect the pulmonary vascular bed eventually, especially in single ventricle and relief obstruction. So I'd like to thank you for your time and attention, and look forward to answering questions at the end of the symposium.
Thank you very much, Ruchi. That was a great talk, very comprehensive, and a great way to kick this off. We're going to move on next and invite Deip Nandi from Nationwide Children's here in Columbus, Ohio, to talk on pediatric heart failure in the absence of congenital heart disease. Deip, if you want to share your screen. And
There, can you see my slides?
Yes.
I
Great.
see them now.
Great. Thanks so much, Dr. Merman, and the rest of the panelists, and many hearts for inviting me to speak on this subject for you. Ruchi, that was a really impressive set of slides to get through in 15 minutes, congenital heart disease and how that affects heart failure. And so thank you for that setup. I'm going to be talking about pediatric heart failure in the absence of congenital heart disease. And I'll try similarly to get through as much as I can in 15 minutes. I think it's important, as Dr. Garg had touched on, our definitions and symptom of the syndromes matter. So heart failure, I think of as a three-part definition. It's a clinical and pathophysiological syndrome, meaning it's not just one thing I can say causes heart failure. It's taking that patient as a whole, leading to impairment of ventricular filling or ejection of blood. The blood's not getting through the heart and to the body, and it's thus leading to inadequate end organ perfusion. This idea that the organs themselves need to be perfused, and that's going to be a different barrier for each different organ and for each individual patient. But taking all of that together leads to the full syndrome of heart failure. Now, I'm a simple guy, and I like to leave things in simple buckets. And by keeping things in simple buckets, I try not to miss things. But at the same time, this is a gross oversimplification, but it gets us most of the way there in terms of how to think about these patients. So when I think about these general causes of pediatric failure, there's of course the congenital heart disease syndromes that Dr. Garg just took us through that lead to that syndrome. And then there's a couple other ways of thinking about it. One is the one we most commonly reach towards, that there's not enough cardiac output, and I'll spend the most time on that. There's also the set of diseases where there's too much afterload, or we're asking too much of the heart itself. And then lastly, there's what we call inappropriate loading or poor loading conditions of the heart, which lead to another form of heart failure. Now, each of these are certainly overlapping ideas. And like I said, this is a gross oversimplification, but it allows us to put in context each of these different diseases and diagnostic dilemmas we have to undertake to understand our patients. So we'll start, of course, with that biggest bucket, not enough cardiac output. Now, in each of these buckets, I also like to think of patients as having primary or secondary causes. Primary meaning what's really intrinsic to that heart muscle, and secondary, what's something outside of the heart, maybe affecting the body, that is having a secondary effect on the heart. So, of course, when we think about causes of heart failure in pediatrics and a primary not enough cardiac output, that's when we start thinking about our patients who have a genetic cardiomyopathy, and most commonly, of course, being a dilated cardiomyopathy. For those of you who don't look at a lot of echoes, I'll be showing a couple of clips here just so you can, and hopefully, picture being worth 1,000 words, get them more in your brains. This is, of course, an echo where the right images are tissue and black being blood. You can see here, this is the right atrium and right ventricle, left atrium and left ventricle. And this left ventricle is dilated. It's globular, unlike those other pictures that Dr. Garg was showing us of some hearts to start with. And this the ventricular septum here that separates left and right ventricle is bowed from the right to the left. It's thin, doesn't contract as much as you'd like, and this is clearly a form of a dilated cardiomyopathy. There are other forms of some more secondary myopathies, which we won't go into in great detail, where the heart's function simply is greatly declined. And those are common in myocarditis and sepsis, which would be common presentations in many parts of the world. Medications are also, of course, can cause secondary cardiac dysfunction, speaking specifically of medicines such as calcium channel blockers in infants and neonates, as well as chemotherapeutic agents in the treatment of cancer that can lead to significant dysfunction. But staying with the thread of dilated cardiomyopathy for a second, we think of dilated cardiomyopathy as being sort of bimodal in age distribution, meaning it affects mostly two age groups. The most common age group that it strikes is in our infants. 4.4 per 100,000 infants less than a year of age is to our best knowledge from some population level studies in the US and Western Europe, as opposed to 1 to 2 per 100,000 children in total. There's probably a slow uprise in adolescence as well. So really infants and adolescents. And as for what the cause is of dilated cardiomyopathy, the common teaching from somewhat older data, but still mostly relevant, is that it's mostly, we can say, we don't fully understand. It's idiopathic in up to 50 to 2/3 50% or 2/3 of our patients, we just fully don't understand the cause of their dysfunction. When a cause is found, roughly half of those patients may actually be a form of myocarditis in which the function of the heart declined and never recovered. In another 26% of those patients, the cause of the dysfunction may be neuromuscular in nature, such as muscular dystrophies, such as Duchenne muscular dystrophy or others, in which the dysfunction of this muscle applies to not just skeletal muscle, but throughout the whole heart, including the heart as well. We commonly have said familial at 4%, although I believe this number is greatly increased in recent years as we've done more and more understanding of genetic causes. And I'd say in as many as 1/3 of the patients in whom we are able to send genetic testing on, we're able to find and identify a mutation which is causing their heart disease. And then also a small percentage of these patients are due to inborn errors of metabolism, those in whom are unable to tolerate the basic carbohydrate or protein metabolism that is normal to the rest of us, that then leads to significant cardiac dysfunction. Now, sticking with these dilated cardiomyopathy patients as well, I wanted to just review a little bit more of the physiology and how this forwards into the symptoms that we see. So this is a picture of the Frank Starling curve, which tells us how we believe the heart muscle to operate in a significant portion, in that the heart needs to be loaded to a certain extent in order for it to eject to a certain extent. Now, the other way of thinking about this is that the heart is a rubber band, and you pull the rubber band back and you let it goes across the room. Now, if you don't pull back very hard in the rubber band before you let go, of course, the rubber band doesn't go anywhere. That means you have to load it properly. And conversely, if you load it way too hard, you can snap the rubber band and it goes nowhere and provides no forward motion at all. And the heart acts in the same way. We have to load it appropriately. Now, when we take my cartoon heart here, and we have the onset of left ventricular dilation and dysfunction, as we showed in that one echo picture, what happens first is that we usually have venous congestion. When we talk about venous congestion below the heart, that's often causing congestion in the liver, causing hepatomegaly and liver failure, abdominal congestion with abdominal pain, early satiety, not wanting to eat as much, nausea, and vomiting. Similarly, when that blood gets congested upwards, that congestion leads to backup of fluid in the lungs with shortness of breath, orthopnea, dyspnea, cough, and general respiratory distress. That in turn also is a hallmark of the increased pressures within the heart, which pushes the patient further along the bad part of that Frank Starling curve, where they're distended and their heart is further and further not operating well. And eventually that is going to lead towards episodes of low cardiac output. Now, where the blood is just not getting to the tissues that it needs to. Now, this may manifest as low blood pressure, but it doesn't necessarily to start with. But it certainly can manifest as decreased organ perfusion. That's affecting all the organs, which leads to fatigue, behavioral changes, abdominal pain, renal failure can all present with this as well. Now, the body, of course, sees that this is happening and undertakes what we call a neurohormonal activation. It's a pre-programmed response where the body is trying to increase the perfusion to its end organs. And it does that by releasing your endogenous adrenalines, gets your epinephrine, norepinephrine, gets your body's heart rate and blood pressure up, trying to push more blood through to your organs. It activates the renin and angiotensin systems, which constricts your arterioles, which increases blood pressure to a point, and can help increase for tissue perfusion distally, although it is also increasing work for the heart to do to generate those higher blood pressures. It also activates aldosterone, which then in turn has us activate and retain sodium and water. That sodium and water is meant to push up our body volume of fluid in the arterioles and vascular system to thus increase perfusion to a point, but then can also thus lead to edema. So all of these are compensatory strategies that the body tries and tries and tries to push forward to activate and maintain end organ perfusion. But as we all know, kids are amazing beings that can compensate and compensate and compensate until they can't, until they reach a point where one extra stressor on the system causes them to significantly decompensate, which is sometimes when we see these patients. This compensatory state leads to also adverse left ventricular remodeling, where the ventricle itself struggles to do the right things and puts down more scar tissue, puts down less functioning myocytes, and in turn feeds back into this bad cycle of left ventricular dilation and heart failure. Now, I don't want to forget about my other buckets that I mentioned at the beginning. And so I want to go through those for a second before we talk about how our patients look. So the other two buckets I mentioned, one was the too much afterload. Again, there's primary and secondary reasons for that. When we talk about too much afterload in some patients, we're of course talking about hypertrophic cardiomyopathy with obstruction when we're talking about cardiomyopathies. And so again, you can see how thick this left ventricle is and how thick this septum is. And over here on the right-hand side, where blue is the color of blood as it is going away from the bottom of the screen, you can see how there's obstruction to the blood getting out of the heart. The heart's so thick, the blood can't get out of the heart. And some of it is indeed backing up into the left atrium. And by backing up into the atrium, it's causing lung congestion. While with blood not getting out of the heart, that's causing the heart to feel more and more stressed. The patient may start to be syncopal or have passing out events, have chest pain. And over time, a heart that is severely obstructed is going to weaken over time and have just general failure of pump function as well. Now, with hypertrophic cardiomyopathy, this is perhaps much more understood than dilated cardiomyopathy, primarily because of its increased prevalence. We think it's as common as 1 in 400 or 1 in 500 patients, people rather, and it is a disease of sarcomeric structure, the macrostructure of the myocytes themselves, which leads to hypertrophy of the myocytes and then macro hypertrophy of the heart muscle cells themselves. This can present with obstruction. It can also present without obstruction, but all of these patients also have decreased diastolic filling. Because we understand it better, I'd also say our genetic understanding is better as well. And in as many as 50% or more of patients that we have found hypertrophic cardiomyopathy and that we can now send genetic testing for, we find their genetic cause in about half or more of those patients. Now, that setting of too much afterload can also happen for other reasons, congenital reasons such as coarctation of the aorta, where the heart is having to push and push and push against that coarctation, or an interruption of an aorta, which then leads to severe dysfunction as well. There can also be secondary causes of too much afterload, such as severe hypertension or tumor or mass effect impinging on the outflow tracts of the heart, pushing on the pulmonary artery or on the aorta itself. This is actually a picture of an echo from a young man with an adrenal secreting tumor with endogenous high levels of epinephrine with blood pressures in the 200s over a period of weeks that was unrecognized. And you can see how the heart is just not moving very well. It's not squeezing. And for my heart failure colleagues on the line as well, you'll see also some organized thrombus at the apex of the heart as well. And then there's that third bucket I mentioned, which is the inappropriate loading of the heart, where the preload is just incorrect. And so there are primary causes of this. And so the diastolic heart failure is the classical idea we think of as the restricted cardiomyopathy. And this is a restricted cardiomyopathy echo on the left here, where the heart just cannot relax enough to allow blood flow easily into the heart. The blood is backing up in this gigantic, massive left atrium. Both sides of the heart are affected in this patient, left greater than right. But this is very significant, very severe. The restrictive cardiomyopathies are amongst the more rare forms of cardiomyopathy and amongst the most deadly, often because they're picked up so late in their course. Hypertrophic cardiomyopathy patients and even late states of dilated cardiomyopathy also have impairments of diastolic filling, but obviously not as severe as this. And then there's secondary causes where the heart cannot fill very well. And those include sepsis, tamponade, and hypovolemia in general. So here is an echocardiogram of a patient with a large pericardial effusion. The heart is floating in this black fluid, and you can even see how here the right atrium is being compressed by this fluid as well. And because the right heart is compressed, you can also imagine then that blood from the system of the body is not returning to the heart very readily either. So taking all of those buckets together, what do our patients look like when they present to us? The cardiac presentation primarily happens, but it's probably a little bit rare when we have presenting symptoms of being palpitations and chest pain and gallop type murmurs, gallop rhythms, where the heart itself is the real reason the patient is presenting, or their heart-directed symptoms. In fact, as Dr. Garg mentioned as well, we have similar very common causes of presentation: nausea, vomiting, weight loss, hepatomegaly, all of these GI symptoms. Children are much more symptomatic from these generally. Respiratory symptoms are also not uncommon: shortness of breath, tachypnea, difficulty breathing in different positions. Having enough heart failure to present with poor urine output to start as a starting presentation would be relatively rare, but certainly can happen. And then neurologic, certainly with decreased perfusion to the brain and just all of the neurohormonal activation, there's certainly behavioral changes, and in some patients who also sometimes become less active, recognizing what is stressing that system out and stressing that patient's body out. And lastly, I come to what we call the heart failure assessment square. And this is the idea that when we're assessing our patients, we tend to look at two sides of their body. One is what is their fluid status, and what is their perfusion status. So by fluid status, I mean simply, are they wet or are they dry? Are they full of fluid? Are they swimming in edema and lungs full of fluid? Or are they dry, presenting as you and I should? And then how is their perfusion? Are they warm? Are they having a good cap refill? Do they have good blood pressures? Are they well perfused? Or are they cold? Do they have poor blood pressure? Do they have poor end organ perfusion already? So we think of patients who are warm and dry as being in their best presentation state. That's the well-compensated patient who we can have time to enact good therapies on, as opposed to our warm and wet patients who are a little bit worse off. They're full of fluid. They're full of cough and congestion in their lungs, edema, and big livers, as opposed to patients who are cold with poor perfusion already, where they have all that edema but already have low blood pressures, or potentially even harder to treat sometimes as well, are poorly perfused patients with low blood pressures who do not have an easy target of edema to treat to get them on the right part of the Frank-Starling curve. So this is a whirlwind tour of the many, many types and presentations of heart failure outside of congenital heart disease, but I hope I've queued up Dr. Shaddy well to talk about medical and supportive therapy for heart failure in children. Happy to take your questions as we progress.
Dr. Nandi, thank you. That was a great overview. And I know the time restrictions for each of your talks made it hard to cover all the things we wanted to, but thank you. And I do think that sets it up very nicely for the next talk by Dr. Bob Shaddy, who's coming to us from Children's Hospital Los Angeles in Los Angeles, California. And he's going to talk to us about medical and supportive therapy for heart failure in children. I believe a nice segue.
It's sharing this over here.
Are you able to see my slides?
Yeah, I can see your slides now.
Okay, sorry for the, all right, there it is. Okay.
Perfect.
Thank you. Sorry for the delay, for the technically challenged. So thank you, Darren, and thanks to the Mending Hearts organization for this opportunity to be with you today on the third Mending Kids Virtual Educational Symposium. So these are my disclosure. I am a consultant for 3 drug companies looking at bringing drugs to children. I'll be talking about current management of really heart failure with reduced ejection fraction, which I'll refer to as HFrEF, and I will be talking about some newer therapies as well. So as Dr. Nandi pointed out, this is what I'll be talking about today. This is a still frame of a dilated cardiomyopathy with a dilated left ventricle. And for those of you who've seen these kind of patients before, very often the still frame is not a lot different than the real-time echo as well. But this can happen in both dilated cardiomyopathy or congenital heart disease, and either one is possible. And we'll talk about different kinds, mainly dilated, but it also includes left ventricular non-compaction as part of dilated cardiomyopathy, but also hypertrophic and restrictive briefly. And then there are some acquired conditions like myocarditis or anthracycline toxicity, and rheumatic heart disease can be part of this, was related to the mitral valve and aortic valve and Kawasaki disease. So Dr. Nandi talked about this briefly, this concept of warm and wet, cold and dry, and cold and wet. And now we'll be talking about some of the different treatments for this. So in a situation of warm and wet, you have increased filling pressures, you have pulmonary and or peripheral edema, but with adequate perfusion. So the primary therapy here is diuretics. And we really try to get diuretics into these patients as soon as possible. If they are on chronic heart failure medications, those should often and can often be continued. And if they're mildly symptomatic, one who is not on medications can be started on things like ACE inhibitors, beta blockers, or mineralocorticoid receptor antagonists. With someone who's moderately symptomatic, you may need to start getting into drugs such as milrinone or other IV medications. For those who are cold and wet, they have increased filling pressures but poor perfusion. Again, diuretics are indicated here for someone who is wet, and you can continue someone who's on chronic heart failure medications unless there's concerns of blood pressure and or kidney function. You need to consider milrinone if the blood pressure is stable and or adequate, but if hypotensive, you need to consider inotropes with alpha adrenergic properties such as dopamine or epinephrine. There are supportive management therapies that one can consider, such as decreasing oxygen consumption, such as avoiding fever and tachycardia. Intubation can be necessary in someone who has pulmonary edema, and if you have capabilities, it's important to consider having anesthesia available and sometimes even mechanical support available, because these patients can, if they're very sick, can fall apart with intubation. Sedation is often helpful in this setting as well. You also can increase oxygen delivery, such as making sure that they're not anemic. You can use judicious fluids, and this is where monitoring of your central venous pressure is very helpful. And judicious use of inotropes is also sometimes something that can be useful. When thinking of inotropes, remember that catecholamines stimulate beta-1 and beta-2 receptors and increase the heart rate, increase myocardial oxygen consumption, and often have alpha adrenergic stimulation, which results in vasoconstriction and increased systemic vascular resistance. And that's why using these phosphodiesterase inhibitors, also called inodilators, such as milrinone, will decrease systemic vascular resistance, increase inotropy, and have much less increase in heart rate and myocardial oxygen consumption. Now, we don't have access to levosimendan in the United States. It has not been FDA approved in the US. That is another drug that people have found useful outside of the United States. For monitoring purposes, I think there are some things that can be monitored. I've found in the past using a superior vena cava or mixed venous oxygen saturation to be helpful to monitor how you're doing with regard to your therapies and your interventions. Central venous pressure monitoring can be helpful for right-sided pressures. It may not help you at all with left-sided pressures. And things such as urine output or laboratory evaluation for end organ perfusion can be helpful as well. Now, there are some guidelines that were published by a group of us from the International Society of Heart and Lung Transplant years ago. And we have a group of class 1 indications, although unfortunately the level of evidence is C, meaning expert opinion without good data to support it. One of these is an ICU setting at a pediatric heart failure center should be considered if possible. Cardiac catheterization if there's evidence of ischemia and or congenital heart disease without non-invasive diagnosis of the etiology of the heart failure. Temporary use of IV inotropes in heart failure patients with cardiogenic shock and poor perfusion, and considering vasodilators or again inodilators such as milrinone in the absence of hypotension, and diuretics for fluid overload. And those are really our class 1 indications. So when we think about our current pediatric heart failure therapies, we do have a handful that are used, although we have limited evidence to support the use of all of them. So diuretics for fluid overload. In the absence of fluid overload, there really is no indication for diuretics. ACE inhibitors or angiotensin receptor blockers if intolerant to ACE inhibitors. Mineralocorticoid receptor antagonists such as aldactone or eplerenone for symptomatic heart failure. Beta blockers and those with a systemic left ventricle. Digoxin for persistent symptoms. Those are currently the indications in adult heart failure, and I've mirrored those as well, not using digoxin as a first-line drug. Cardiac resynchronization therapy for dysynchrony, low ejection fraction, and moderate to severe heart failure, and I'll show you what indications there are, and these are rare. This is rarely indicated in children. implantable cardioverter defibrillators for low ejection fraction and appropriate risk factors, and milrinone with inotropic escalation for severe heart failure, and two topics that our next speakers will be talking about: mechanical circulatory support and heart transplant for end-stage heart failure. So what about cardiac resynchronization therapy, or CRT? And these are again from the Pediatric Heart Failure Guidelines. These can be useful in children with a systemic left ventricle, ejection fraction less than 35%, with a left bundle branch block, which is uncommon in children, and a prolongation of the QRS that is greater than the upper limits of normal for age, and symptoms, either New York Heart Association class or Ross class symptoms on maximal therapy, on maximal ACE inhibitors, beta blockers, mineralocorticoid receptor antagonists, et cetera. And this is only a class 2A indication with level of evidence B. Implantable cardioverter defibrillators in children with heart failure can be useful in children with unexplained syncope and at least moderate LV dysfunction and a dilated cardiomyopathy. This is a class 2A indication, level of evidence C, meaning expert opinion, and can be considered in pediatric patients with dilated cardiomyopathy with an LV ejection fraction less than 35% who are symptomatic on maximal medical therapy. Again, this is a low indication, a class 2B indication. And this was a study from the Pediatric Cardiomyopathy Registry from years ago, trying to identify those who are at high risk for sudden death, presumably from ventricular arrhythmias. And they took a group of patients and identified those who are very dilated or higher risk, those that are younger than 14 years of age are at higher risk, and those who have thinning of their posterior wall. And they made this ratio of the LV posterior wall thickness to the end diastolic dimension of the left ventricle. And these were patients who are at the highest risk for sudden cardiac death and should be considered for possible candidates for ICDs. I do want to talk about a few new medications. One is ivabradine and the other one is Entresto. So ivabradine is a drug that works exclusively on the sinoatrial node, and it works through the IF or I-funny channel. And its mechanism of action is to mediate slowing of diastolic depolarization, thus slowing the heart rate. And this is done without any direct myocardial contractility effects and no blood pressure effect. And in a study that was done in children, after some adult trials had shown that it works well in adults, Damian Baudet led an international study with ivabradine compared to placebo in 114 children with a 2-to-1 randomization ratio. And the primary endpoint in this study was a reduction in heart rate. So not surprisingly, those who got ivabradine did have a reduction in heart rate compared to those on placebo, and it was shown to be safe. They looked at a secondary endpoint of left ventricular ejection fraction, and this showed some benefit as well. If one looks at placebo, there was an increase of about 7 EF units in those who got placebo over the 12-month period of the study. However, in those who got ivabradine, they showed a larger increase in their EF units, and this was statistically significant, suggesting that it not only lowers heart rate, but it may improve function as well, and therefore improve outcomes in heart failure. If looking at the current guidelines from the European Society of Cardiology, if one uses diuretics and ACE inhibitors and adds a beta blocker and is still symptomatic and adds a mineralocorticoid receptor antagonist and continues to be symptomatic with a low ejection fraction, less than 35%, and still has a higher heart rate, then one can add ivabradine. And this is why it's probably not used very commonly in children, because in general, we're able to control heart rate and these other things with the use of our current therapies without ivabradine, but it is indicated and approved for this. So let's talk about LCZ696 or Entresto, and this is an angiotensin receptor blocker, and remember that therefore this will reduce vasoconstriction and reduce sympathetic tone and other effects, and is a neprilysin inhibitor, and an ARNI drug it is called. And a neprilysin inhibits many things, but neprilysin is ubiquitous throughout the body. From a cardiovascular standpoint, neprilysin's main effect is through inhibiting the breakdown of natriuretic peptides, which then results in more vasodilation, reduction in sympathetic tone, etc. So in the landmark Paradigm HF trial in adults, which was done in over 8,000 adults worldwide in over 1,000 centers, they were able to demonstrate in a head-to-head trial with enalapril a 20% relative reduction in the primary endpoint, which was heart failure hospitalization and mortality, and a 3.2% absolute reduction in the primary endpoint. And based on this, it was approved for the treatment of heart failure in adults in the United States and throughout the world. Its current indications are for symptomatic adults with heart failure with reduced ejection fraction. One should switch from a stable regimen of an ACE inhibitor or an angiotensin receptor blocker to LCZ696 or Entresto. So based on this, a group of us got together and worked with Novartis to set up a pediatric trial called the Panorama HF study. And this was a part 2 study. This was a poster we presented at the European Society of Cardiology years ago. And there was a 2-part study. There was a pharmacokinetic and pharmacodynamic portion of this study in 3 different age groups, 6 to 18 years of age, 1 to 6 years of age, and 1 month to 1 year. And as we determined the appropriate dosing of the drug, patients then moved in that age group into the part 2 trial, which was a head-to-head trial of sacubitril/valsartan, which is Entresto versus enalapril. And I'm pleased to say that we completed enrollment in January of this year. We had over 130 sites in over 35 countries worldwide. And once patients complete the 52-week portion of this trial, which will be next January, we will then have the results of this study. Interestingly, in October of 2019, in the middle of the trial, Entresto was approved by the FDA for symptomatic heart failure in children as young as 1 year of age. And this was based on an analysis in 110 patients from the Panorama HF trial, evaluating the reduction from baseline to 12 weeks in the biomarker NT-proBNP. And it showed that it was equivalent to enalapril. And based on this, they felt it was considered a reasonable basis to infer improved cardiovascular outcomes in children. And this was approved now in the United States for the treatment of heart failure in children. So there are some special heart failure situations, and myocarditis is one. And currently, using the things that I mentioned earlier, supportive therapy is indicated, and the benefit of things like intravenous immunoglobulin and steroids is still debatable. Hypertrophic cardiomyopathy, Dr. Nandi talked about, but if you have a reduced LV ejection fraction and you have what's called burned out hypertrophic cardiomyopathy, you need to consider the same therapy as above, but in that situation, heart transplantation is usually necessary. And with restrictive cardiomyopathy, our real options are only diuretics and anticoagulation. And again, heart transplant is usually indicated in this situation. So has this shown really any benefit? And this is a publication from about 4 years ago on HFrEF in adults, and looking at the change in the hazard ratio with adding these therapies. So if you take an ACE inhibitor, you reduce the hazard ratio in heart failure with reduced ejection fraction to 0.83. If you add a beta blocker to the ACE inhibitors, the study shows it reduces that to 0.57. If you then add a mineralocorticoid receptor antagonist, the hazard ratio goes to 0.44. And if you substitute an angiotensin receptor neprilysin inhibitor like Entresto for the ACE inhibitor, that hazard ratio is even lower at 0.37. So these drugs do work. And we were able to show recently that they also work in children. And this was the first study showing survival in 2 different eras. Here in blue is the 1990 to 1999. And with the therapies that we mentioned and the therapies that are going to be mentioned in our next few talks, we were able to improve outcomes in children with dilated cardiomyopathy. So if you look at all these therapies that we have available, I would just like to add that if considering an ACE inhibitor or an ARB, now one of the options is an angiotensin receptor neprilysin inhibitor or Entresto. So thank you very much for your attention.
Dr. Shaddy, thank you. That was excellent, and thank you for sharing updates and knowledge on some of these new medications that not only work for heart failure in adults, but are clearly showing evidence to work for our pediatric population as well. So thank you very much for that. We're going to move on next to the next talk, which is basically talking about next steps if medical therapy is not enough for our patients. And it's an absolute pleasure to welcome Dr. Vivian Dimas from Medical Center Children's Hospital in Dallas, Texas. And she's going to talk to us about ventricular assist devices for pediatric heart failure, the current state of the art. Take it away, Viv.
Thank you. Can you see the correct screen?
Yes, I can see your slides nicely.
So thank you, Darren, for the opportunity, and thank you to Mending Kids. And Dr. Shaddy, I'm not exactly sure I'm capable of following that, but it's a nice segue into my talk, which is discussing what happens when medical therapy begins to fail and what are the options. So there are a lot of devices. And so the question really is, how do you pick the device? And the type of device is based on the type of support needed. So when we go down the device algorithm, the first things we're thinking about are, is this an acute decompensation? And is it something we need to rapidly deploy? Are we in an acute resuscitation? If we have some time to think, we discuss the length of support desired. Do we think there's a possibility for recovery? Or do we think that we need to decide this once we get the patient rescued, and whether that's transition to a more durable device, bridge to transplantation, or bridge to decision that maybe the patient isn't suitable candidate for either a durable device or a transplant. It's nice to have the option to make that decision. The patient size and weight obviously factors into what devices are able to be used, and we'll discuss that shortly. And then the cardiac anatomy, it becomes more complicated when you have congenital heart disease, particularly when you go down to the single ventricles versus the options for structurally normal hearts. And then finally, what are the lungs like? Do you need oxygenation? Because that also will affect what device you ultimately choose. So when we think about it in congenital heart disease, there's really the two subsets. There's single ventricle and two ventricle. And then what I have down here is the temporary devices versus the durable devices, and temporary meaning things that we would place in the cath lab percutaneously. And then the other discussions that we had about age and weight. And I would argue that the two ventricle applies not just for congenital heart disease, but also for just biventricular circulation with acute decompensation. So it's easier to talk about the biventricular options because there's more. Looking at percutaneous mechanical circulatory support, so things we can do in the cath lab. So selection continues to remain limited, and I'm sad to report that there really hasn't been much progress in pediatrics, although there is a lot of effort towards progress. We just haven't made much headway there, mainly due to size limitations. These devices were all created for adults, and so we have, as a community, been able to figure out how to use them in larger children and teens, but they all typically require some modification. And the current devices that are available are balloon pumps, the Impella line of catheters. I have percutaneous heart pump written here because it was in trials, but the trial's been halted, so I'm unsure if that will ever be a device that's going to be available. The tandem heart, which is also available, and ECMO, of course, or extracorporeal membrane oxygenation. In terms of the percutaneous options, this is just a picture schematic talking about the balloon pump. So the balloon pump is a counter pulsation, so it augments diastolic blood pressure. We use that a lot less in children because it's typically not coronary disease like it is in adults. So it can increase afterload, and diastolic augmentation isn't as helpful as ventricular unloading to reduce the left ventricular and diastolic pressure and then subsequently improve coronary blood flow. When you look at the continuous flow pumps, there's the Impella, and then the percutaneous heart pump, which I just mentioned, which was in a non-inferiority trial with the Impella. It was called the SHIELD 2 trial, but again was halted for the second time in March. So unclear if that will finish trial and come to market. On the centrifugal flow devices, the only percutaneous real option is tandem heart, although if you place the cannulas percutaneously, you could just say VA ECMO can also be placed in the cath lab, and we are doing more of that. The limitations in pediatrics are really related to size. And when we talk about LVADs, that's really arterial size. And I only put this up here to give you an idea of how big these catheter sizes are. So the Impella LVAD really needs a 13 or 14 French sheath in an artery. So that limits you in terms of your pediatric patient selection. Now, a very new device that's currently in trials is their expanded CP, which is going to be a 9 French motor and 9 French catheter. And then we'll have an expandable nitinol cage that will give you the same flow as the CP, which is about 4 liters per minute indexed. So that hopefully will be a great option for us. Those trials are beginning in 2021. And so we will we'll be following that closely, I think, from a pediatric standpoint. The tandem heart is really big. The catheters are large in caliber, but they're also long. So the 21 French venous cannula has to be placed transeptally. And then you really, the best you can do for arterial flow would be a 12 French, but it requires dual cannulation. So both arteries have to have a 12 French catheter in them. And I think for most of our patients, that's very prohibitive. The PHP I put up there again, the one that was halted, that's a 13 French. So it's very similar to the currently available Impella devices. And then the other restrictions are anatomy. If you've ever placed these devices, they can be very difficult to place in repaired congenital heart disease with aortic artery constructions or VSD patches. So it is a little difficult to get around the anatomy. And then the chamber size, because again, these were created for adults. So they have a particular length from the inflow to the outflow that can't be changed. And so we've written some papers talking about these modifications, but again, they have to be modified. They're very difficult to use in pediatrics in the way that they are currently labeled for use. We now have options for the right side. So there is an Impella RP. Again, it's large. It's a 22 French pump. It goes through an 11 French catheter, and it provides about 4 liters of flow. And this was one of the first percutaneous VADs where the labeling was changed from an age from adults to just a body surface area. So this can be placed in pediatric or adult patients who have a body surface area greater than or equal to 1.5. And then I put PDMAG and CenterMag down here on the bottom because you can actually place these cannulae. And there's a schematic where you'll see here that there is a cannula in the PA and then one up here in the RA and SVC. So you can place bypass cannulae percutaneously and then attach this to the pump. Surgically placed devices, I broke this up into age groups. And again, there are some devices we're going to talk about that coming up that may or may not ever make it to be commercially available. Right now, when I think about infants, we talk about sort of the less than 8 kilo group. And so what I would say here is ECMO is the most commercially available, sorry, it's commercially available, but the most available device for most programs. And so a lot of people will go to ECMO or a Rotaflow for the smaller patients. The Berlin heart is still available, but as we know, in this particular patient population, there is a high incidence of poor outcome, particularly neurologic injury, and the survival isn't fantastic. And then the PDMAG, which is, I think, being used more and more in this age group. When we get to the older patients, there's just a few more devices that are available. Again, ECMO, I would say, is the old standby. There's the Heartware ventricular assist device, which is an implantable device you see here. There's CenterMag, which is along the lines of PDMAG. And then I have Jarvik here listed, and I have it in italics. So it currently, again, was pulled from trial, and I am not sure that this device will actually ever make it. It had some complications related to thrombosis, but it was probably the only LVAD that had made it this far that would be able to be used in smaller children and down to infants. So I think more to come on that device. And then in the larger children and teens, I think probably the most exciting device here is the Syncardia, the fully artificial heart, which comes in a couple sizes. There's a 50 cc and a 70 cc size. And so in a larger child, the question is this going to be an answer for a lot of our patients who either are sensitized and aren't transplant candidates, or just simply due to the lack of organs available for the growing group of patients who need transplantation. ECMO, again, is always there. And then the HeartMate 3, which is another fully implantable LVAD. And so that's really what we focus on for our larger patients. The univentricular options and strategies are really complicated. And I don't want to make this, this would be an entire talk itself, but it's really difficult to support these patients. So the outcomes are worse when we compare our VADed patients compared to biventricular patients. And it's really difficult to achieve adequate but not excessive pulmonary blood flow in these patients. The geometry and cannula position becomes difficult after these reconstructions, particularly when we're talking about things like bidirectional Glens. And then if there's systemic semilunar valve insufficiency, that's another complicating feature. And we found, at least in our practice, that we have been most successful in patients where it's an isolated problem of reduced ventricular function, and we're simply trying to unload the ventricle. When you start adding the other features in, it becomes much more complicated and they're much more difficult to support. So the ongoing challenges, there's still no ideal solution for single ventricle support. Complications continue to exist from all of our VAD placements, including driveline infections, the risk of thrombosis, there's risk of neurologic injury, hemolysis, and sensitization from multiple blood products that are received. So for future directions, these are really all meant to deal with the challenges that we talked about before. So the Fontan blood pump actually has been around for a while, and in September of 2020, it just received about a $9 million grant for study with hopes to have a device available for investigational device exemption by 4 years from now. So 2025, potentially we might have an option. And this device is something that is designed specifically for Fontans. You actually advance it here up into the Fontan circuit, and it acts as a pump, sending blood out to the branch pulmonary arteries to promote blood flow through the Fontan pathway. So I think this is exciting that it's gotten some funding, and hopefully this will be something that we'll have in our armamentarium in the next 5 or so years. And then other things to combat the issues that we've talked about. So driveline free power source is really coming around. Most of these are by transcutaneous energy transfer, and there are already some wireless ventricular assist devices that are out there coming to trial, and they've actually proven that they are able to run LVADs with this. So this will be driveline free energy for these implantable devices. So I think that would be a game changer if this comes to fruition and makes it through trials. And then finally, I think the non-blood contacting VADs, these are probably more realistic for our adult patients or the larger teens, but the goal here really is to try to get ventricular assist device technology that is one, wireless, and two, doesn't have the blood contact to avoid those risks that we talked about with hemolysis, stroke, and the need for the same type of anticoagulation. And with that, I'll end it. I know mine was short and sweet, but I'll get us back on track, hopefully. Thank you.
Vivian, thank you very much for that really interesting talk. We're going to move to our last talk, and this is from Dr. Chris Almond from Stanford University up in Palo Alto, California. And he's going to talk to us on some of the updates and current results on neonatal, infant, and pediatric heart transplant. Dr. Almond, please take it away.
Hey, thank you very much. Just a screen check here. Can you see my screen?
Yes, I can.
Okay. All right, thank you. So it's a real pleasure to be here, and also to listen to the other speakers. Vivian has done so much really interesting stuff with the Impella device and others. It's really great to hear the experience. I'm going to talk about neonatal, infant, and pediatric heart transplant and some of the current results. And it's a real pleasure to be here. I do have some grant support for a couple of trials, but have no financial conflicts of interest. What I'd like to do today is just to review briefly the major indications for pediatric heart transplant, donor selection and survival, to briefly discuss some of the immunosuppressants that we used most often today, to briefly review the 5 major complications of heart transplant that essentially limit its survival. And lastly, I put together a top 10 list of what I think are some of the most exciting and innovative trends in pediatric heart transplant. Now, I would be remiss if I didn't mention that the world's very first heart transplant was performed in Cape Town, South Africa on December 3rd of 1967, and that was by Christian Barnard, who ended up on the front page of Time magazine. I remember one of the quotes that he was noted as saying is that on, I think, what was it, a Monday, nobody knew him at all, and by Tuesday, everyone around the world knew him. I've actually had the honor of visiting the museum there, and it's a spectacular experience. What's really amazing is that since then, there have been over 10,000 pediatric heart transplants performed in the United States alone. And last year, over 600 were performed in children. This is just below the age of 18. So things have really come a long way. And this is a very typical case, a 6-year-old boy with trisomy 21 and a common AV canal defect whose status post-repair is admitted to the hospital. He's got severe heart failure with an EF of 18% and severe mitral regurgitation. He's in low cardiac output and edematous, so he's cold and wet. So he's intubated and placed on dopamine, epinephrine, and milrinone. He worsens, requiring chemical paralysis, and he has long runs of non-sustained VT that surface despite antiarrhythmics. He's brought to the lab where his wedge pressure is 32, his RA pressure is 18, his index is low at 1.7, and his PVR is elevated at 7. He has a number of other risk factors, including severe malnutrition. He's got a GFR that's in the 30s, and he has a total bilirubin that's quite elevated at 4. So if we estimate his mortality risk, it's well over 98% without advanced cardiac therapies. So first, I'd like to review the major indications for heart transplant. And this is kind of boiled down to one slide, but it's essentially severe heart failure. It could be either due to cardiomyopathy or congenital heart disease, requiring hospitalization that is unresponsive to medical therapy. So basically what we would call stage D heart failure, end stage heart failure, and hospitalized. If patients are not hospitalized, if they have severe limitations to physical activity, have growth failure, life-threatening arrhythmias, or have pulmonary hypertension in the setting of restrictive cardiomyopathy, provided it's reactive, patients are also eligible. The main idea here, regardless of what is driving transplant listing, is that the expected survival without heart transplant should generally be considerably less than with transplant. What are the contraindications to transplant? It's irreversible multi-system organ failure, severe fixed pulmonary hypertension, inoperable pulmonary artery hypoplasia, and retransplant for rejection or in the early months after initial heart transplant. Now, this is a distribution, age distribution of kids receiving a heart transplant, and this is from an international cohort through the ISHLT. And you can see that infants less than 1 year of age are the single most common age group that are actually transplanted. And then you can see the rest are actually relatively low frequency relative to the infants. Now, congenital heart disease predominates in the smaller patients because of the incidence of congenital heart disease at birth. And then cardiomyopathies like dilated cardiomyopathy tend to predominate in the older age groups. And if you look at this same data as a pie chart, you can see that for infants, congenital heart disease, depicted in blue, accounts for 3/4 of the transplants, whereas in adolescents, it accounts for only 1/4 of the transplants. And in children between those two age groups, the mix is about the average of the two. Now, what about survival? It's important to know that this depends on age. So if we look at infants, after a heart transplant, their 1 year survival is 82%, which is actually the lowest of all age groups. but by 15 years, and the overall median survival are actually the highest in transplant medicine. Children actually are in the intermediate age group. And then you can see that adolescents, who have the highest 1 year survival rate at 88%, actually have the lowest median survival and long-term survival rates. So most people will put the median survival of patients who are transplanted in the current era around 17, but it does range quite a bit by age. And that this flip in the curve, that the short-term survival is best among adolescents, but is best long-term among infants. If you're more than a visual person, you can see this red and these green curves kind of cross, maybe at about 6 or 7 years, where the infants start out worst with early postoperative problems, but have the longest survival. And that's likely because of immunologic privilege that's conferred by transplanting early. So how do we choose donors for recipients? Well, they essentially must be matched by two things: body size, and different groups use different numbers here, 90 to 150% of body weight. There's a real trend actually moving toward direct measurement of total cardiac volume, because body size is an imperfect measure of heart size. And then blood group. And the only exception here are infants where ABO and comparable heart transplant is possible. Other factors: brain death is generally the cause in most cases in the United States. Good LV function, lack of trauma to the heart for contusion of the heart, and then generally a short ischemic time. We generally want that to be less than 4 to 6 hours, which limits the distance to less than 2,400 kilometers. So what about immunosuppressants? We basically group these into two categories. One is short-term or induction immunosuppression, which is used by a little over half of programs. And this is essentially a high dose of a medication to blast the immune system. Probably the most common one is a form of thymoglobulin that comes from rabbits that essentially nukes all of the lymphocytes that are involved in rejection. And this essentially allows us to delay some of the long-term medications that have more side effects, like kidney problems, which can be difficult to start in the early postoperative period. And then we have maintenance immunosuppression, which is generally long-term and oral, and these are forever medicines. And the most common combination that's used currently is tacrolimus and MMF, or Prograf and Cellcept, and over 70% of programs currently use this. The major side effect of tacrolimus, which is a calcineurin inhibitor, is really kidney and in some cases coronary disease, although it's probably not linked to the tacrolimus directly. Other medications like sirolimus, which is an mTOR inhibitor, or the preferred term now is a proliferation signal inhibitor, since it has more effects than just the mTOR effect, is quite useful, and it's believed to prevent progression of coronary and kidney disease. So oftentimes it's used in patients who actually develop either of those two complications. So I'm going to talk about the 5 major complications of pediatric heart transplant that essentially limit survival to about 17 years. And we'll do this in a quick case format, but this is a 15-year-old girl who underwent a heart transplant 2 years ago for dilated cardiomyopathy. She recently began taking over responsibility for taking her medications, but has missed a few doses. She now presents with a 3-day history of nausea, vomiting, and fatigue. On exam, she's tachycardic to the 120s. She has mild tachypnea and a new S3 gallop. Her extremities are warm with good pulses, suggest good cardiac output, and an echo shows moderately depressed LV function. What's the most likely diagnosis? And here the most likely diagnosis is cellular rejection. It does peak early after transplant when the heart and recipient are getting to know one another. And then in adolescence, again, it comes up probably because kids are starting to take responsibility of their medications, and non-compliance is more common. Risk factors include prior rejection, non-adherence, and African-American recipients. Clinical presentation is quite variable. Actually, many cases are entirely asymptomatic, which is why programs do surveillance biopsies in otherwise healthy kids who come in from school to have their screen for rejection. They typically will have elevated filling pressures or a BNP, and the diagnosis is made with a biopsy, at least historically. Here's a second complication that's a problem in transplant. A 14-year-old girl, status post-heart transplant 7 months ago, who presents with fever, pneumonia, diarrhea, and fussiness times 2 weeks. She just discontinued her valganciclovir a few weeks ago. What's the most likely diagnosis? And this is CMV infection, cytomegalovirus infection, which is actually something that was quite lethal early in transplants. And over time, people have developed medications to essentially make it much less of an issue than it used to be. So most of our patients are still on some form of CMV prophylaxis. The biggest risk factor is that the donor is positive and the recipient is negative. And it's well known that CMV is a potent risk factor for cardiac allograft vasculopathy. There are a variety of reasons for this, but oftentimes you'll see that CAV presents sometime after CMV infection. Fever, pneumonitis, and GI illness tend to be the presenting symptoms, and it's either diagnosed by a CMV PCR or could be done with serologies. And the treatment is one of the ganciclovir, and most patients in the US are ganciclovir sensitive. This is another complication. Here's a 6-year-old boy who underwent heart transplant for DCM 5 years post-transplant. He presents with a 6 months history of significant weight loss and abdominal pain. A CT of the abdomen is obtained, which shows multiple nodules and masses around the stomach and small intestine. What's the most likely diagnosis? And this is post-transplant lymphoproliferative disease, PTLD. And it's basically a form of cancer malignancy, but it relates to having too much immunosuppression. This reminds us that our immune systems are responsible not only for combating infection, but also being on the lookout for cancerous or cancer-like cells and neutralizing them. But when the immune system is suppressed, these cells can proliferate out of control. And the clinical presentation is pretty variable, but abdomen, oropharynx, and chest tend to be the places where these masses tend to develop the most. The vast majority of these are driven by Epstein-Barr virus, the virus that causes mono. And patients who are immunosuppressed can't essentially control the proliferation of the bug, and it oftentimes then stimulates white cells to proliferate. Generally, lowering immunosuppression is the treatment for this, and in some cases where it's very similar to a known kind of cancer, like a B-cell lymphoma or diffuse large B-cell lymphoma, it's treated with traditional chemotherapy. And lastly, here's a 14-year-old girl who underwent heart transplant 5 years ago for DCM. She's on a VAD for 6 months. She became moderately sensitized. Her post-transplant course was complicated by rejection and CMV, and on routine angiography, she was found to have the following images. And you can see this angiogram has lots of little pock marks out of it. Very different from traditional coronary artery atherosclerosis, where there's a single lesion oftentimes in one of the vessels, and this is inflammatory. This is a leading cause of late graft loss. CMV, recurrent rejection, AMR are all risk factors, and most patients will switch over to a PSI. Retransplant, this is the #1 cause for retransplant in patients. So briefly, a top 10 list, and I did this in an order where anyone could argue with how I've sequenced them. I also did them a little bit mostly toward organ allocation first, but so the top 10, kind of number 10 would be ex vivo perfusion. As you know, as I mentioned, we have to do transplants within, say, 1,500 or 2,000 miles, but if the heart could be essentially preserved in a beating solution, that you could actually transfer the heart across the United States or perhaps even further. ABO, incompatible heart transplant, was really popularized by Canada, and Laurie West was really at the center of that. And that's become incredibly important. I think probably 15 or 20% of infants in the US now are transplanted against blood type. DCD donation and use of marginal donor hearts. This has become increasingly common. As I mentioned, most hearts are donated after brain death, but that can be complicated to diagnose in infants, which might account for partly for the scarcity of donor hearts. And a variety of organizations, including Action and others, have been working on this. Great Ormond Street Hospital in London has really been doing a lot of DCD donation recently. And it would be very difficult not to mention that the first heart transplant done in, say, Cape Town, South Africa was a DCD transplant. There are other ways marginal donor hearts are being used, including from hepatitis C infected donor, and the outcomes have looked comparable to non-infective donor hearts if therapy is given. Number 7 is innovation in organ allocation. There's been a lot, mostly in the lung allocation system. There's actually an effort now to try to improve the current one because it's difficult to show that the most recent revisions have actually made any difference in overall waitlist mortality. So this is an active area of innovation as well. Another place is the reduction of racial disparities. There are the gaps between Black, Hispanic, and white outcomes not related to medical factors is still present, but it's far less than what it was before. This is a paper by T.P. Singh, who had looked at this, and a lot of the gaps have closed. Long-term survival, though, still sees a disparity. There have been ethical advances. I think for a long time, cardiac transplant was the only organ that used neurologic disability to exclude patients. This has changed substantially in the wake of a number of publications. The patient that we just mentioned had trisomy 21 or Down syndrome, and for a long time has been a contraindication to transplant. There's been a much more recent sense that your level of neurologic disability should not be a factor, provided that it won't alter survival. And so that's been important. And also looking for socioeconomic disadvantage, not to exclude patients, but so that any risk factors could be neutralized, like not having a car or some other factor. Let's see, number 4 trend is that single ventricle heart disease, I think, is poised to overtake DCM as a leading indication for heart transplant in the United States. You can see the growth here. These are some UNOS data. I think DCM that year, as I looked at it, was maybe 285 cases. So you can see that this is really about to eclipse DCM. And this also is leading to a lot of combined transplants. Here's an en bloc liver transplant and lots of discussion about transplant for Fontan-associated liver disease. Novel immunotherapies, there have been a whole number of things, mostly in AMR. These are neutralizing antibodies, whether it's IDIS or a variety of other kind of synthetic antibody neutralizing drugs. In the pediatric heart transplant world, we've done we just completed enrollment in our first randomized trial of everolimus in pediatric heart transplant to see if it lowers long-term complications after transplant. Non-invasive surveillance of rejection, almost everyone still does biopsies, but a growing number of centers are actually just doing a blood test to exclude rejection. If there's a concern, they'll still get a biopsy, but this is a real game changer, potentially. It's already made its way through the adult world and now is being investigated in children. And then lastly, and I just wanted to mention this, is really the VAD therapy revolution for kids. These are now going in over half of DCM patients listed for transplant and a growing number of congenital heart disease patients. These are percutaneous devices like Vivian mentioned, the HeartMate 3, other devices. This is the PD-MAG that's being used in a newborn. And this is the Jarvik here. The Jarvik actually is active in trials, in a feasibility trial, and a pivotal trial is being developed currently, which was green-lighted by the FDA. So that's essentially it. How did our patient do? He was implanted with a Hartwell LVAD, did well. His nutritional nutritional status normalized, but his kidneys didn't recover. So he was listed for a combined heart kidney transplant, and he's doing well 4 years later with no significant rejection. So in summary, more than 600 pediatric heart transplants are performed annually each year in the US. And actually now there are more outside the United States than inside the United States, which changed recently as well. Median survival is about 17 years. It's limited by 5 complications. And the field of pediatric heart transplant is rapidly growing and evolving, making it a fascinating field. But all of that began in South Africa back in 1967. So thank you very much, and I'll stop there.
Dr. Almond, thank you for that extraordinarily thorough and informative talk. I really appreciate that. So I want to be sensitive to the time across the world, but there have been a few questions posted, and I'd like to jump into them. The first question posted, let me just pull it up here. I had it here a second ago, but it just went away. Was posted by Stephen Nagusa, and I was going to direct this one to Dr. Nandi. And he was really asking about the role of viral myocarditis to the etiology of dilated cardiomyopathy in children. Dr. Nandi, do you want to comment?
Yes, please. I think this is a great question, Stephen. We do not fully understand dilated cardiomyopathy, and we think there is likely a significant role that viral myocarditis plays in the pathogenesis of that. I think Dr. Tobin and others of the Texas Children's School of Thought certainly feel that it might be responsible for as much as a majority of significant cardiomyopathies. We have a hard time knowing, and that's just based on our limited data and understanding. We think that if the myocarditis leads to ongoing inflammation and fibrosis that then leads and propagates to heart dysfunction in a heart that is adversely remodeled, and then it presents as a cardiomyopathy down the road, we may have missed those early findings, viral studies that may have time to find the viruses that may have caused it. I think a conservative estimate would be that as many as 1 in 5 dilated cardiomyopathy patients may actually have had myocarditis in the past. There's also an idea that there's sort of a 2-hit factor going on here, where one patient may have a predilection towards heart dysfunction that is unmasked by a viral myocarditis. So significant is the answer, and I wish I could be more specific. I don't know if the other panelists want to chime in.
Thanks, Deip. There's a general question that maybe I'll direct to you, Dr. Shaddy, and others can chime in and comment afterwards. But really sort of asking about high output cardiac failure and just sort of explaining it a little bit, and perhaps an example and its effects on the heart, and if there are medical management therapies even possible for it. Dr. Shaddy, you're muted. If you want to just unmute, please.
Okay, can you hear me now?
Yes, perfect.
Thank you. So that's a great question, but I can tell you I know very little about high output cardiac failure because I've seen very little in my career. So when I can think of it, I've seen it in arterial venous malformations where someone has a cerebral or hepatic malformation. Then I would be contacting my interventional colleagues, 2 of which are on the call here, and to say, can you help me out here? And then thyrotoxicosis, which I don't know if I've ever seen high output failure with thyrotoxicosis. I know it can happen. But again, the treatment of it is going to be managing the underlying problem, and the secondary effects on the heart and on the pulmonary and systemic circulation will be resolved if you can treat the primary problem. So that's been my experience. If anyone else has a different experience, I'd love to hear it too.
No, I think that's sort of a very nice description of what it is. The couple of cases I've encountered through the years have been in different age children and some neonates with, as you alluded to, a cerebral AVM or a vein of Galen malformation, where it requires a fair amount of collaboration with neurointerventional radiologists who have some of the techniques to try to get up there into that AV malformation and try and help occlude it. but it's really treating the underlying problem as the main mechanism for trying to overcome the high output failure, as you said. Yep. So I haven't seen a lot of other questions posted. I was going to just throw out one for Ruchi. Ruchi, you gave a sort of very nice overview. It's a very hard topic to try and cover in 15 minutes. But I suppose I would say if you had to choose one or two management strategies, it could be medical or non-medical, that you could try to target to that newborn or infant that's got a overwhelming congenital defect that's causing significant volume overload and pulmonary overcirculation, sort of one or two management strategies to try and target to help that child through?
Absolutely. And I think probably many of the attendees on this call have a wealth of experience with this, because fortunately, in most of our centers that the speakers are coming from, we always have the option of early surgical intervention, but we certainly try to postpone surgery, as I mentioned, to optimize outcomes. So calories are a big focus, and getting calories either through volume and then diuresing the extra volume off to the point that the kidneys can tolerate, and concentrating calories. So we give fortification into breast milk or formula, sometimes adding in oils to get our caloric density to 30 calories per ounce versus the usual 20 calories of straight formula. And we really monitor weights because we want the patients to not be in a catabolic state, because that defeats the purpose. If they're losing weight, they're not growing well, they're just so susceptible to infection and compromise. And so the big target is there. And then diuretics are really often sufficient as a first line, but are the first drug that we really utilize and optimize. And there are a few different types of diuretics to be used, loop diuretics being sort of the first. But there's always considerations because of premature infants having a little bit more organ susceptibility. So we found that ACE inhibitors are really something we try to avoid in the really young babies, because sometimes it's just a little too much of a stress on their kidneys.
Thanks, Ruchi. I don't see any more questions posted. I thought I would throw one more out there and perhaps direct it first to Chris Almond, and then see if others want to comment as well. But it really, one of your slides sort of struck the question in my mind, alluding to transport of donor organs. And I know that there's been fairly some big steps forward in trying to preserve donor organs in terms of how far they may be able to travel. And can you speak perhaps to some of those technological advances that have been coming out recently that may allow for more global organ transplantation, or may make it more feasible for organs to travel thousands of miles to make it to other places that may not have been possible before?
Yeah, the main system that's out there is this OCS system that was the subject of clinical trials. And it looks like at least the early outcomes of those grafts appear to be comparable to traditional storage. The way we store things currently is really it's pretty prehistoric. It's essentially in an igloo box with ice that's around it. And you might imagine that might kind of, just like something in your freezer, it tends to freeze the outside of the allograft, but people have shown that there's a temperature gradient as you go more and more toward the center, where it's warmer. And perhaps this is the reason that we tend to see kind of septal problems at the crux of the heart as kind of isolated findings with traditional storage patterns. But the long and the short of it is, yeah, this is exciting. Now, most of it is really only suited at this point for larger grafts, kind of adult size grafts. As you know, every time you miniaturize something, you run into problems with clotting, whether it's a heart pump, a dialysis machine, or an ex vivo perfusion system. So I think working out some of those details so that it can be done adequately is still work that needs to be done. So I think it's, yeah, one of those very promising things, and really could create a much more efficient kind of clearing market, if you will, for organs where we can really match them to patients and factor in distance as a secondary issue.
Thanks, Chris. Any other comments or thoughts on that from others? Okay. There was another question out that was posted, and let me just see here. It really, and this could be for anyone who wants to take it. It's from Leah Plusenza. She's asking about duration of medical management for heart failure, and perhaps how long one can give vasoactive agents to our patients while perhaps trying to support them through either to some recovery of myocardial function or perhaps to further advanced therapies.
Deip, why don't you take that?
Sure. That's
Sounds
a tough.
good.
That's a tough question. Really, it depends on the goals for the patient. And that's where we always have to be directed and what our goal is for our patient. And, you know, in some resource intensive areas of the world where we have the options of heart failure and transplant, if that's our goal, we can go on inotropic agents for quite a long time or other heart failure medications. But I think if the answer is how can we make our patients feel the best that they can while they're awaiting their next step in life. And so I think the answer may very well just, it's so individualized. I will state that there are many patients in whom we think, you know, we should throw in the towel and head for heart failure and transplant advanced considerations that we're on very great maximal medical therapies. And if we give it enough time where they don't have worsening end organ dysfunction, we can wait for quite a long time and give patients the time to have myocardial recovery, which can happen. Then there are some patients who require inotropic agents that we can't get them off. These inotropic agents often have a shelf life to them. Patients respond to milrinone, but only for a period of time. However, if that's compatible with the patient's life goals, and we have sent patients home on milrinone sometimes and can remain on milrinone, dopamine, dobutamine, and other such inotropes for months, if not years. I will say some of these chronic therapies that we're also providing for heart failure, such as ventricular assist devices. You know, my longest patient now I'm running is 3 years on HeartMate 3. And I'm sure the other panelists have patients who are running as long. But I think if we base those on the goal of the patient and family and where we want to go with them.
Darren, I have a quick thought to that as well. If it's I wonder if the person who's asking the question is thinking about the adult guidelines, which say that long-term use of inotropic agents actually is class 3 harm for patients, so is contraindicated in chronic heart failure. And you know, I think that this is one place where pediatrics, I think, does tend to be a little bit different, is because the randomized trials showing that inotropes were harmful to adults really may not be applicable to kids, because we tend not to have as much of the arrhythmias and some of the problems that accounted for the higher mortality in randomized trials of inotropic agents in the adults. So yeah, we do seem to get away with them much more so than the adult world does.
Yeah. Thanks for that. So I do want to be a little sensitive of time. I know it's quite late out with our friends in Tanzania and other parts of Africa and the world. I don't see any other questions. Christina, if you see any other questions that I missed, please let me know. But with that, I thought we'd wrap it up. I'd really like to thank, first of all the speakers for doing an excellent job. I know I probably gave you one of the hardest tasks which was taking a big topic and trying to get it done in 15 minutes. So thank you to all of you for your time and effort and commitment to this. Thank you to Christina and Isabel again for your dedication and energy that you put forward with this. I've really enjoyed working with you through these different symposiums. And most importantly, thank you to all the attendees for really what's at the end of a long day, joining in the evening and nighttime to listening to us and engaging with us. So thank you to everybody. I've really enjoyed it.
Thank you, Dr.
Christina?
Berman. Thank you, Dr. Berman. On behalf of Mending Kids, I want to thank everyone for participating, our panelists, our Dr. Berman, our attendees, especially Edwards Life Sciences, who provided the sponsorship for this symposium. It was wonderful. So thank you so much for joining us. And we look forward to sharing more symposiums with all of you guys. So please stay tuned. Thank you.
everyone.
Thanks,
Thank you.
everybody. Bye-bye.
Thank you all.
Guys.
Thank
Well,
Thank you,
you.
everyone. Bye-bye.